Hello, everyone. I am Erica Daniels, founder of Hope Grows for Autism. We are so excited to have Dr. Bonni Goldstein once again to share her groundbreaking research. Dr. Goldstein is a pediatrician in Los Angeles. She is the medical director of Cannabis Centers and serves on the advisory board of Pharmacometabolomics. Today, she is here and going to share with us the results of her groundbreaking research in autism and cannabis and the pharmacometabolomics. It's very interesting information, and thank you for joining. Off to you, Dr. Goldstein.
Thanks so much, Erica. And I'm really excited to speak about my research. Today, we're going to talk about cannabis and autism, specifically using a fairly new technology called pharmacometabolomics to assess efficacy of treatment in patients, specifically in my research in patients with autism. So just a little bit about me. I've been a California physician 31 years. I trained at Children's Hospital as a pediatrician and went into the practice of pediatric critical care transport for a few years, and then started working in pediatric emergency medicine, which I did for about 14 years or so. In 2008, I became a cannabis specialist after witnessing the benefits of cannabis medicine in a friend of mine. And it just intrigued me. I couldn't believe what I was seeing. And I wanted to have more regular hours as a mom. So I switched over, and it's been really an incredible journey. I've been medical director of Cannabis Centers Wellness and Education, which is here in Los Angeles, where we treat patients with cannabis, and also recently joined the advisory board for a group called Pharmacometabolomics. And the research that I'm presenting today was in collaboration with Pharmacometabolomics. Also, I just want to point out, I did write a book. This is my second book on cannabis, and it's called Cannabis is Medicine: How Medical Cannabis and CBD Are Healing Everything from Anxiety to Chronic Pain. And it's available on Amazon. It was published just about a year ago. And it's really meant for anybody interested in learning more about what's in the plant, how does it work in the body, what conditions it can be helpful for, and also really the latest research that shows its benefits. And that's important because we've had a huge amount of research in the last decade, 2 decades, which really counteracts kind of all the garbage we were fed back in the day about how cannabis is a drug of abuse only. And that is certainly not true. In the world where we prescribe medications, we kind of assume, oh, okay, here's a medicine. We write a prescription and we give it to patients. This is as clinicians. And we often ignore the fact that people are different. It's not one size fits all. It's not everybody responds the same to this medicine. There are so many factors that determine whether or not you're going to respond to medication. It's important to understand that your genetics plays a role. More and more, we're understanding that your microbiome, the health of your gut, the bacteria that live in your gut, play a huge importance in how you respond to medication. Your physiologic factors, your gender, your age, whatever diseases you have, or you may be being treated for one condition and that's going to affect another condition. Combination of drugs. I know in my practice and with children that have epilepsy and autism, they're on a multitude of drugs by the time they get to me. And will that influence how cannabis will work for them? Those drugs interact with each other even, so we know that. Also, environmental factors like your lifestyle, your diet, and then, of course, the big unknown. How do we know there isn't something else that's affecting? And so there's all of these factors involved, and yet in the world of medicine, we kind of have this tenet, oh, well, you have this disease, so this is your drug. And that's just, I think, not really appropriate anymore. And we're living in the world now of more personalized medicine, more customized medication regimens based on some of these factors. And this is where pharmacometabolomics plays a role in looking at specifics for any individual. And let me get into that. So what is pharmacometabolomics? And so the definition is the systematic identification and quantification of metabolites in an organism or a biological sample. So just the same way you can draw blood and look at a drug level, look at your glucose level, your white blood cell count, this is a measurement, identification and measurement of metabolites, which are these small molecules floating around your body. A metabolome refers to this group of metabolites. And in our research, we're looking not at drug metabolites or breakdown products of drugs, but we're looking at chemical pathways in the body that help with inflammation and bioenergy and pain and emotion. And so that is what we kind of call the metabolome, is this group of compounds that are collected, looked at to assess the biochemical pathways in a specific person. And so again, this field of science is often used to research the drug effects on individuals. How we want to understand the action and metabolism of the drug, understand the factors that can alter the breakdown of a drug in any specific person. And so, for instance, there's been some research looking at simvastatin, which is a very commonly prescribed, one of the top drugs in the United States, prescribed cholesterol lowering medication. And in the research looking at pharmacometabolomics and people who were using this drug, they found that the health of your gut impacted how this drug worked. It correlated to the response. And nobody discusses that with patients. We don't talk about that. And that's very important. If your gut is not healthy, taking simvastatin, you're putting it in your body, maybe getting side effects, but not getting the benefits. You say, oh, I don't respond to that drug. But maybe it's because the health of your gut is not where it needs to be in order to potentially benefit from this drug. This is how pharmacometabolomics is being used. So ultimately, it allows clinicians to predict efficacy and toxicity of drug treatment, but also to personalize treatment for a specific individual. If I was able to help somebody get a better result from a medication, whether it be cannabis or something else, based on this data that we collect from you, then certainly that's in your best interest. Just kind of willy-nilly giving out medication without really addressing all these factors really is somewhat obsolete at this point. Now, how does it work? What do we actually do? So we collect samples from the patient, and pharmacometabolomics can work on any biologic fluid. So plasma, which comes from your blood, spinal fluid, even biopsy tissue. And in our case, we use saliva. And what happens is the sample, as you can see down here in the schematic, you can see the biofluids are collected. And then what happens is the metabolites are extracted out and separated. Then they're quantified using a process called mass spectroscopy, which is highly sensitive in detecting all these different metabolites. And you can see the little graph here. Sorry, it's so small, but you can see all these different peaks. They reflect all the different metabolites and how much is in there. And you get this raw data. And then what happens is then the data is interpreted. And there's actually special software, specific software that measures these changes in metabolites over, let's say, before you take a drug and after you take a drug. And so, and I'll share that further in the study. But it's a pretty complex, but it's certainly not difficult. And it's certainly not more difficult than what we're kind of doing now in the data collection and sample collection world anyway. So here's the title of the article that we published: Cannabis Responsive Biomarkers, a Pharmacometabolomics-based application to evaluate the impact of medical cannabis treatment on children with autism spectrum disorder. And I just want to put out there, this is the beginning of this type of research. This certainly is not the end-all be-all. There will positively be more studies down the line. So we're starting here with this like core research, and then what happens is we keep adding on, and that's where we really get to a point where we understand the actual application of using this type of technology to assess treatment response and to help customize treatment. So in our study, we looked at what's called cannabis responsive biomarkers. So what are biomarkers? These are molecules found in bodily fluids that are signs of either normal or abnormal processes or of a condition or disease. And we are using them to see how well the body responds to a treatment. And the main biomarkers that we looked at include the metabolites with roles in inflammation, bioenergetics, amino acid metabolism, brain cell activity, and the endocannabinoid system. All of these parameters are crucial to patients with autism and other conditions as well. But for autism, we know that all of these parameters are involved in the etiology of autism and the ongoing treatment of autism. So let's go over the participants. So inclusion criteria. So how did we recruit patients? So the patients had to have a diagnosis of autism spectrum disorder diagnosed by a qualified healthcare professional. They had to be taking medical cannabis for at least 1 year under medical supervision with signs of improvement based on parental reports. We did not want to use patients who were still trying to figure out their cannabis regimen, as that could change the results. We looked at patients between the ages of 6 and 12, and the reason we didn't go younger was just for sample collection reasons, and we didn't go higher was because, as everybody knows, puberty kind of kicks in and can start to change things, and we're trying to want to leave out the hormonal influences in this particular study. And then the patient had to be able to donate saliva comfortably without any, discomfort to the patient. Exclusion criteria. So any child who required cannabis treatment more frequently than every 8 hours. And this is because we had a washout period of 8 hours in order to be able to collect a sample that was not influenced by cannabis. We also kept out anybody with traumatic brain injury because we know that that can change some of the biochemical pathways. And then also we excluded anybody with a dual diagnosis of autism and epilepsy because we wanted, again, to focus on autism. And then as our control samples, we recruited children who were what we call typically developing or neurotypical. And the inclusion was same age group, 6 to 12, no individual diagnosis or immediate family history of established or suspected developmental disability. And also the participant hasn't received any type of special education evaluations or services, just to make sure that our control sample wasn't anybody who was potentially on the spectrum. Because again, when you're doing research, you want to make sure that your controls don't overlap with your study population. So the study design, we ended up recruiting a total of, we had more patients, but who ended up being in the study was 15 patients with autism. The average age was 9.4 years, and the male to female ratio was 8:1. We made sure that they had no cannabis for 8 hours before the saliva collection, which was done in the morning. And for samples collected before the medical cannabis treatment, what we called right? So pre-treatment, 20 minutes before the saliva collection, the child rinsed their mouth. 10 minutes before the collection, the parents completed a brief behavioral survey. Now, they did do a number of surveys prior to the collection. So even beforehand, once they were enrolled and they met all the inclusion criteria, they went through the longer behavioral surveys, which I'll show you the results of that. But right before the collection, there was a brief behavioral survey. And then we went ahead and collected the saliva. And then about 90 minutes after treatment, after they got their morning dose of medical cannabis, we collected another sample, which we called peak, because it seemed that the peak effects were around 90 minutes and the parents start to see the cannabis kicking in. And again, the same procedure was followed with the rinse and the behavioral survey. And then for the children who were our controls, we had 9 children, average age very similar, 9.3 years, and same male to female ratio. And we collected saliva in the morning only. And then here you can see the chart of our patients. And so their ID number, so they were basically blinded, their ages, their genders. Now this is their dosage per day. So some children had 1 dose per day, some children had 2, some had 3, and this is morning, noon, evening, is what their normal cannabis regimen consisted of. And then here you have the cannabinoid content. And as you can see, there is no standard here. These are all patients who were under medical supervision. And when they started their cannabis treatment, they started with one particular compound, and then over time, with the typical kind of trial and error that people go through to find a cannabis regimen, this is what these patients kind of ended up on. And you can see it's really interesting. We have patients as low as 10 milligrams of CBD and as high as 200 per dose. We have patients here that have no THC, and others that have very high doses. Like here we have a patient with 50 milligrams, and then you can see the other cannabinoids as well. And we tried our best to be able to collect all of this data, and be aware that edible doesn't mean like a gummy. It really was that what happened is some of these patients, the way they take their cannabis oil is together with food, and we consider that more of an edible, as opposed to a tincture that a patient might hold under their tongue and then swallow. And I think it's not a perfect science in terms of when you're giving a child medicine. All parents know this. Sometimes they spit it out, sometimes they hold it in their mouth, sometimes they swallow it quickly, sometimes they hold on to it for 2 minutes and then swallow it. So it does certainly vary. But again, these families were experienced with giving cannabis for at least a year. And so we felt that the method they were using was pretty reliable. Now, here's the behavior ratings before cannabis. So what you can see here is across the top is the IDs, A1 through A18 for the children. Each one of these is an individual child. You can see one family, A2, did not give the behavioral surveys, but we included them anyway. And then there's 3 types of behavioral surveys that were used: the BASC-3, the SRS-2, and the ABAS-3. And what you can see here is that red is kind of in the severe category, severe behaviors. And based on, you can see here the different colors for the different types. Overall, you can see a lot of red, a lot of orange and pink, or on the red scale, a fair amount of blue at the top as well. But what you can see is that we found 11 children were considered to be severe behaviors, 1 child moderate behavior, and 2 children mild behavior. And this is before the cannabis treatment was given. And then behavioral ratings after cannabis. So meaning they got a dose and then we reassessed, the parents filled out the behavioral surveys. And so what we found was 11 children improved, 2 children with mixed response, and 2 exhibited increased difficulties. And this was on the day of saliva collection. But what you can see here is blue is improvement, lots of blue, right? And then no change was the yellow. And then worsening, you can see scattered around. And, sometimes patients have a bad day on the day that they're that we happen to be studying them. They're just like us. They can have a bad day, and that's what can happen. But the overall, which is so interesting, and I'm sure if you've read about cannabis and the use of autism, this is why it's a hot topic, is because clear cut, there's definite improvements that we are seeing in these patients. And so the idea is that before treatment, there was a lot of severity, and then after treatment, the majority of patients improved. We detected in the saliva 484 known metabolites, and out of all of those metabolites, 65 were identified as cannabis responsive biomarkers for autism spectrum disorder in at least 8 up to 15 of the children with autism, meaning that these were the biomarkers that changed in response to treatment. 31 of the 65 were detected in all of the participants, and 21 of these exhibited statistically significant change, what we call a p-value, which means that it wasn't due to chance. It's due likely to the treatment. P-value was less than 0.05, which is used as a standard in most studies. So pretty interesting. Okay. Now, this is where it gets a little confusing, and don't worry if you don't understand this, because the next few slides will explain it. But Canformatics came up with these algorithms, and it's the way to measure the meaningfulness of the change. And so they have an algorithm called count patient diff up down. So basically it counts the number of children with autism in the study who showed either an increase or a decrease in the concentration of metabolite after cannabis treatment. Then they have a second algorithm to be able to compare, and they call it compare patient to neurotypic. And what this means is they calculated the mean of the metabolites relative to the typically developing participants. And we used what's called standard deviations. So plus or minus 0.5 standard deviations from the mean is just a slight outside of the mean. The higher that number, whether it's positive or negative, gets you away from the mean, is kind of those metabolites are off. And then using a medical cannabis, what we were looking at is, does it bring those metabolites closer to the mean? So that's the whole idea here. And this allows us to calculate the movement from before cannabis treatment to after, pre to peak, relative to the physiologic range that we found in the typically developing patients. So I think this will help explain it. This is just 3 of the patients, and you can see we've put also their cannabis regimen next to them as well. So this is, so for this patient, age 11, who's taking CBD 200 milligrams per dose, these bars that extend are the levels of the biomarkers. This physiologic range, so this line right down here, down the middle of this green, is the mean. This is what in the typically developing children, what the average was for those biomarkers. And then we have the range described as +2 and -2 standard deviations from the mean, okay, to give, because we're not all sitting at the mean. When you look at this patient, who's one of the patients with autism, you can see their biomarkers are skewed, many of them significantly higher than +2 standard deviations from the mean. Same thing for this patient here. You can see a lot of the biomarkers outside of the +2 standard deviations, and the same thing with the patient here. Then the patient gets their cannabis medicine, and we collect saliva 90 minutes later, and we measure those same biomarkers. And as you can see, what happened here was that these biomarkers that were lying outside 2 standard deviations from the mean, outside of what we determined to be the physiologic range, corrected into the physiologic range. And it's pretty obvious to see this significant change, right? That all of these biomarkers are now falling close to, or the mean within, the physiologic range. And you see the same thing here and the same thing here. It's pretty interesting. Now, not every biomarker corrected, and I wouldn't expect it to, because cannabis isn't magic to be able to do that. But certainly this gives us a picture as to how patients are responding. And our hope is then to look at individuals' specific biomarkers to see, how is cannabis helping? Is it biomarkers that reflect inflammation? Is it biomarkers that reflect aggression? Is it biomarkers that reflect neuronal dysfunction? So there's a lot of data here, as you can see. And I just want to point out that we have a second paper coming out early next year, because we did get so much data from this study. But I think that this slide, I'm going to show you a whole bunch of other slides, but I think this slide clearly shows that cannabis can help bring patients back into what we call homeostasis, or balance. It helps balance all of these chemical pathways that we're looking at here. Here's another graphic from the paper. The pie chart shows, this is before medical cannabis given, 19% of patients had their biomarkers fall plus or minus 0.5 away from the mean. And as you can see, 15% were greater than 4 standard deviations away from the mean, whether above or below. And then after medical cannabis treatment, more patients fell into closer to the mean. So when you get to the lower number, you're closer inside that physiologic range. And so 19% had biomarkers that fell within the standard deviation, which we would consider, in the physiologic range. But then after treatment, 36% of the patients fell into that range. And then we saw the number of patients who were significantly out of that range that reduced with medical cannabis. So it helped bring patients closer to the mean. And all 65 metabolites exhibited the trend of shifting the value towards the physiologic range determined by the typically developing controlled children. Now, I'm just going to focus on some of the particular biomarkers, and that we talk about in the study. So there's one called N-Acetylaspartic acid, which we call NAA. And it's a highly abundant neurochemical which reflects neuronal density and viability, meaning how many brain cells and how well they work. Research reports that there's significant reductions in NAA in individuals with autism spectrum disorder. And by the way, that's measured through functional MRIs and other types of scanning. And this significant reduction indicates some neuronal dysfunction, some brain cell dysfunction. But interestingly, it's a little conflicting reports. A study showed that in patients diagnosed with Asperger's syndrome, they had higher prefrontal lobe levels of this particular compound. So some patients are low and some patients can be high. And again, we see that a lot with the patients that we see in cannabis, for instance, patients that have low immunity and patients that have overimmunity, right? And so this is not unusual to find this. Now, we saw two distinct groups in our results, which I'll go over. Some patients had significantly elevated levels of NAA. So here you can see study child A2 had very high levels of NAA before cannabis treatment. And then you can see after cannabis treatment, it was measured to be much closer to the mean. This dotted line here is what we would call the mean and what was found in the typically developing, as you can see over here to the right. So, and you can see here, another 4 patients, very high pre-levels of NAA, which then corrected down closer to the mean. Then we saw some patients who were just kind of close to the mean. And so let's say A5 here, they were low and cannabis seemed to bring them closer to the mean. Same thing with A6. Now, there were a few that went down. Remember, there's also a margin of error, so this could be very close measurements. But what's interesting is that, again, A14 here got brought up by cannabis closer to the mean. So it seems that if you're either too high or too low, cannabis kind of helps stabilize. And so we hypothesize that cannabis is stabilizing the levels of this particularly important neurochemical. Again, when we look at cannabis, it makes sense because cannabis helps balance. We talk about homeostasis all the time. It's your endocannabinoid system is a system that is promoting balance. If you're under, it brings it up. And if you're over, it brings it down. And so we saw that with this particular compound. Another compound that was measured was called spermine. It's involved in inflammatory pain, and it does work through what's called the TRPV1 receptor, which is a target for CBD, CBDA, THC. And so there is some crossover there that we already know that these cannabinoid compounds target this receptor as well as this compound. And so this may be a useful biomarker in children with autism who have pain or inflammation. And again, looking here, you can see A2 had very high levels of spermine pre-cannabis, and then it corrected down closer to the mean. Same thing here with A9. You see it with A13, A15 as well, very high, corrected down, very close to the mean. And although this didn't correct completely, it's certainly a significant shift. And again, here is where you would expect this compound to be. And so again, showing us that medical cannabis is, we know, clearly involved in inflammation as an anti-inflammatory agent. And so here we were able to get measurement of potential anti-inflammatory effects. Another compound that we looked at is called DHEA-S. So it's dehydroepiandrosterone sulfate, and this is a chemical that we all have that's a precursor, lives in our adrenal glands, and it's turned into basically hormones, male androgens and female estrogens. Previous research found high levels in this compound in children with autism. And there's a number of research reports that the high levels are associated with aggression and psychiatric disorders. Now, our results didn't meet significance for change, but 3 of the 7 patients who were older, so of our 11 and 12-year-old cohort, these patients, you can see here, A15, A16, and A18 had significantly high levels of DHEA sulfate. and taking cannabis helped correct it closer to the mean. And again, this is quite interesting because remember, these are children who we may say are prepubertal, but certainly we know in 11 and 12-year-olds, they are likely in puberty. And I just found this to be very interesting because, again, it correlates with aggression. And some families do report that right around puberty, their child starts to have more outbursts or becomes highly aggressive toward others or even towards themselves. And so very interesting results here as well. And by the way, in the scientific literature, you can't include everything because you have to have a certain, they won't publish a 42-page research. So we have other findings that we don't necessarily talk about. We did put in supplementary data. So if you go to read the paper, at the very end, there are links to the supplementary findings. And so I do have included some of that, but it's very important to understand that we only focused in the paper on just a handful of the biomarkers. But we, again, are publishing a second paper because we do have so much data. Now, what are the limitations? So, not all research is perfect. And so unfortunately, we just had a small sample size. I will say cost is an issue because this costs some money to do all of this research. And so with only 15 patients, it gives us an idea. But remember that if we expand that and we have many more patients who can go through this research or testing, we can then have a much larger data set to predict which biomarkers are super important, which ones we can ignore, but also include the full spectrum because our patients there's only 15. So certainly this doesn't reflect the large variation in a population of patients with autism. We were unable to associate the specific cannabis regimen with specific biomarkers, meaning CBD corrected these biomarkers or THC corrected these biomarkers. We did not have enough data to be able to make those associations. And then one thing we did also notice, although in my patients, I encourage them highly to use syringes to be able to measure out dosing. Some parents were kind of eyeballing with eyedroppers. I mean, it was the same dose each time, but again, that may throw off findings only because an eyedropper is not an accurate reflection of dose. The last limitation is that we gave equal impact to all the cannabis responsive biomarkers because at this point in time, we don't know exactly which biomarkers to focus on. Again, we are in the preliminary stages of this type of research, and there may be other biomarkers that, again, in a larger group, start to stand out as more important. And so I'm excited to move forward and expand this research so that we can start to use this data clinically, meaning I have a patient who has not used cannabis yet. We collect their biomarkers so we have a baseline. 3 months into treatment, we collect saliva again and assess. And now I can see that X, Y, and Z biomarkers that correlate with certain symptoms are improved, but ABC biomarkers are not improved. Okay, now let's focus on that. And then we can use it as an ongoing reflection of the chemical changes in the patient. And additionally, we can start hopefully looking at the association with the microbiome in the gut as well, and also a child's metabolism, because this is a big deal with cannabis medicine. I have some patients that seem to metabolize their cannabis very quickly, and some where it kind of lingers for days, and then we end up stacking it as they get their doses and they're not metabolizing it, and then seems like it's backfiring. So it would be really nice to be able to use this non-invasive way of collecting, to go through a blood test or MRI or anything, just spit into a tube, and we can use this to help direct treatment and give us specific information to customize treatment. So this is why I did this research.
And finally, a big thank you and appreciation to Pharmacometabolomics for the collaboration and for inviting me to do this research with them. I feel really lucky to be able to work with them. They're wonderful people, and they really do want to try to help advance medical cannabis in this population. I also want to thank all of the parents and families that donated their time and effort to participate and share their journey with medical cannabis, and also to the families that graciously donated their child's saliva for the control group, as well as two sponsors, Caniatric.com. Ray, thank you so much for all that you do. And also to Whole Plant Access for Autism, which is a nonprofit that helps educate and give resources to families who are looking to use medical cannabis for their children. And then, of course, a big thank you to you, Erica, for all that you do, and for Hope Grows. Thank you so much for allowing me to share my research. So appreciate it. Thanks.
Thank you so much, Dr. Goldstein. What do you hope are the direct next steps for this? What would be the best case scenario to happen next?
What I would love to see is that we do this again, but with a larger population. So we have more patients, maybe include teenagers or do a study in teenagers as well, so that we can kind of separate out, maybe see what the hormonal influences are. Our next paper is focused on the biomarkers that are what we call lipids, or the fats. And remember that the endocannabinoid system is involved, is basically fatty acids. You know, your inner cannabis compounds are made from fats. Cannabinoids from the plant are considered lipophilic fat compounds. And so it would be really interesting to then start to correlate with the endocannabinoid system as well. You know, many children with autism are prescribed pharmaceuticals. And we know that there's 2 antipsychotics that are approved by the FDA, but that there's a whole slew of drugs that are being used off label for these patients, like antidepressants, anti-anxiety medications. And we have no understanding at all of how these medications are impacting any particular patient in terms of objective data.
Right.
So we now have, with this study, objective measurements of chemical pathways in children before and after medical cannabis treatment that we do not have with these other drugs that are being, again, handed out to patients. I understand people, look, clinicians want to help. We don't want to harm anybody. But the reality is that we're handing out these drugs because we're trying to help, but there's not a lot of data to support its use. There's not a lot of families that find that they work that well. And there's no measurement, right? And I hear all the time, for those people who are kind of against cannabis, well, you don't have proof that it works. It's just anecdotal from the parents. I'm sure you've heard that a million times.
Of course. Yeah, of course.
Well, isn't that what happens when you give somebody a Abilify?
It's the same. Yeah.
It's the same. How about with epilepsy? So you send a child home on an anti-epileptic and the parents counting seizures. We
Right.
trust them to count seizures for the pharmaceutical, but here we are saying that we don't trust them to count seizures with CBD oil. And I understand, right?
You're right.
Yeah.
Yeah, that's a
So-
really, really good point.
So I would say that this study is kind of the only published study on objective data measuring a response, a direct chemical response on a treatment being used for autism. And I would say that that puts us at least on an even playing field with some of these pharmaceuticals. And it's also going to allow us to optimize and customize treatment. And that's very important because we already know with cannabis that we are customizing. Everybody kind of falls into their own cannabis regimen. One other thing that I would hope too that we could gain from the data down the line and from future research is, why does cannabis not work for some people? Right? Is it a metabolic issue? Is it the state of their gut?
Right.
Right? Can biomarkers in specific individuals give us information? And then can we overcome that by, let's say, changing a diet, right? Supplementation with, you know, fish oil or zinc or whatever to help establish a physiology that then can take in cannabis and use it, right? So I think that this is just really cracking the door open on this kind of huge unexplored area to help maximize the potential benefits from cannabis.
You're so right. And I mean, this is really groundbreaking, this research. I really thank you again. I commend you. I thank you for your commitment to our community and to not only your patients, but making sure that research like this is getting done at the same time. And without, your efforts and the efforts of your colleagues, families would be a lot less hopeful than they are now. So thank you. Thank you very much.
You're welcome. It's really exciting for me as a, scientist who's been a clinician for all these years to kind of go back in and try to do research. I really applaud Canformatics. And if you're interested in reading more about them, please go to their website. It's canformatics.com. And we're not trying to sell anybody anything. We're trying to figure this out and we're trying to understand. And so that's where it comes from. Anybody out there who wants to fund research, I will share with you, this is very meaningful research. It changes lives and it's going to lead to direct clinical improvements. And so I just tell people too that if you're interested in learning more, please go to their website as well. Okay.
Yeah. Wonderful. Wonderful.
All right. Thank you, Erica, for allowing me to talk about it. I so appreciate your efforts, and you're always on cutting edge as well. So I just appreciate what you do.
Oh, well, thank you. Thank you for joining me again.
Okay. Take care, everybody.